now entering the Pain Pod, sponsored by the Chronic Pain Association of Canada. Are you ready to know what you don't know about chronic pain? We're shining a light on the good, the bad, and the very ugly about living with pain in Canada. No hype, no hysteria, just the truth. And now, here's your host, Anne-Marie Gatto.
Welcome back, Pain Potters. Can you believe it? It's June of 2026 already. And we're just doing, the last few in the series of the last, and maybe we save the best for last. How's that for a mouthful? So today we've got a unique interview. I don't think we've ever had two guests before, but today we do, two honorable guests. So that's something to appreciate. Lots to talk about, but I don't want to minimize anyone's credentials. So please let me explain who our guests are before we get to the question section. So today we have Dr. Sarah Eichberg, who is a sociologist, public health researcher, author, and policy consultant whose work explores how social and structural forces shape health equity, quality of life, and population health outcomes. For more than 2 decades, she's worked at the intersection of social science, public health, healthcare, and policy, translating research into strategies that strengthen communities, improve health, and inform policy and practice. A recognized leader in community-engaged research, Dr. Eichberg has developed and led partnerships that integrate local knowledge and lived experience into public health research and action. As Director of Community Research at Adelphi University, she helped advance university-community collaborations that engage residents and community leaders as partners in identifying community challenges, generating evidence, and developing solutions. Dr. Eichberg's expertise in social theory, public health, and community-engaged research helped shape today's book, the topic, transdisciplinary perspective and focus on place as a critical factor in understanding drug use, addiction, and overdose. This lens helps explain how social, economic, and institutional forces create differing patterns of risk across communities. By emphasizing socio-structural conditions and local content, the book broadens conventional narratives about the opioid crisis beyond individual behavior and supply-side explanations to the environmental conditions from which risk and vulnerability emerge. Welcome, Dr. Eichberg.
Hi, welcome, and thank you so much for having me today.
Oh, it's a pleasure. And as equally valuable, we also have, again, a returning guest, thank you, Lynn R. Webster, MD, who is a physician, researcher, and author who has spent decades working at the critical intersection of pain medicine, addiction, and public policy. Dr. Webster is widely recognized as one of the nation's leading voices on the human and societal toll of the opioid crisis. He is board certified in pain medicine, addiction medicine, and anesthesiology, with over 300 peer-reviewed scientific publications and the book, The Painful Truth, to his credit. He currently serves as a senior fellow at the Center for U.S. Policy. Known for his long-standing advocacy on behalf of chronic pain patients and clinicians, Dr. Webster's recent work marks a crucial shift in the national conversation. He challenges widespread misconceptions about how the crisis developed, looking beneath the surface at the socioeconomic factors that drove it. To meet this moment, he advocates for the structural changes necessary to protect patients and heal vulnerable communities. Welcome again, Dr. Webster.
Thanks for having us, Anne-Marie.
Yes.
Appreciate
now,
it.
I just have to say, if it were possible to take your CV and put them together and they had a baby, we would have this new book called Deconstructing Toxic Narratives, Data, Disparities, and a New Path Forward in the Opioid Crisis. So that is a fascinating and very powerful title, might I say. So how actually did you come together to begin to work on this book?
Sarah, let me take the first question
Yeah,
here.
please do.
You know, um, you know, for most of my professional life, I've lived at the intersection of two very difficult realities: the devastation that opioids can cause, and the indispensable relief they can provide for people living with severe, unrelenting pain. Unfortunately, our public conversation is too often lopsided. It ignores the complexity and it replaces, I think, some nuance and evidence with fear and outrage. So I wanted to write a book that offered a more accurate, compassionate, data driven narrative. And as you can tell from the introduction, that's why I teamed up with Sarah. She has some deep research expertise as a sociologist and provides a great complement to my background in medicine and in policy. She understands the analytical parts of this and brings an analytical clarity to our book, and she looks well beyond the drugs themselves and helped analyze the deeper social structure. So this allows us to take a look at the real root causes of the opioid crisis, but also it brought our two worlds together so that we could trace, I think, a path forward with some vision that can help resolve the problem and prevent problems in the future with drug crises like this.
Right. So you're not just looking at a whole body, you're looking at the whole bodies in their environment.
Absolutely, yes. Sarah, go ahead and speak up. But yes, absolutely, we're looking at from birth to whatever stage in life they are. I mean, that's really the critical part of our book. We're looking at the what we call the upstream factors. The downstream are the outcomes, and the problem we've had generally is to take a look at just those who overdose and the supply side and try to fix it with some harm reduction, which is good, and naloxone. But if we really want to solve the problem, we've got to look at the upstream factors that make people vulnerable to have a substance abuse problem.
Understood. Understood. Okay. So, how do you think then, or how does your book describe how the public conversation around opioids, you said, is so lopsided, and it is, became so focused on prescribing, and it often completely ignores the patients who depend on pain management care?
Sarah, you want to address that?
Sure. So how it became focused on over prescribing because basically that made for a much easier, neater story to relate to the public. It was very linear. It created villains and people that were taken advantage of, and that's basically where that starts.
Yeah, as I said just a moment ago, the real issues that need to be addressed are complex. They're not a headline in a newspaper. They're not a soundbite. They're much more complicated, as anyone will read in our book if they choose to read it. It's a very complex problem that requires thought and analysis and critique of what we've done from really structural problems in our country back 70 years ago in the creation of incentives and the deindustrialization and economic disparity, lack of healthcare, the change in our healthcare system that's made it more profit driven as opposed to focused on patients. So it's a complicated topic to address adequately.
Okay, that makes sense. So smart, neat, linear, people can, I guess, wrap their heads around that if they so
Yes.
choose. Without, and you certainly don't need to be a critical thinker in order to adopt that.
Well, no, of course not. But you do have to not necessarily um, take for granted what has been said. the title of our book is Toxic Narratives. What are toxic narratives? These are narratives that have been repeated so often by trusted sources that people begin to accept them as truth without even a second thought. That's the point. But what makes a narrative truly toxic, rather than just a strongly held belief, is a systematically distorted perspective of reality. And in this way, it leads individuals into harm and sometimes societal division. So it really actually punishes those people who don't fall in line. I think the most important example is, and it's really what drove us to write the book, is the claim that overprescribing created the opioid crisis, and it continues to fuel it, which we know is not true. What it has done, though, is it's created the harm. The result has been devastating for people living with severe pain, many of whom have had to face forced tapers, medical abandonment, intense stigma, just for taking the medications that they need to function.
And often have taken for years beforehand without any problems, just ordinary medications. I remember, I'm old enough, I remember once upon a time I was not vilified, I was not treated as a felon, I was not something to be suspect of. But now all of that's changed. And I've noticed, especially with the newer doctors and the newer pharmacists, because I'm older, they're quite young to me, they have, it's almost like a fear of these medications, like they're terrified to prescribe them or to see someone use them or whatever. Like, I don't know, the sky is going to fall or something. Like, there's just a fear there surrounding the medication, which that never used to be when I was younger. I've been in pain for over 4 years. When I was younger, doctors were not afraid of these medications. They were prescribed regularly.
Anne-Marie, this is exactly our point. What the narrative is and has been really to create fear, and as opposed to an understanding of what the real problems are that could be addressed to improve the situation, if not resolve it. But fear is a part of the narrative that has been damaging.
Right. Okay. I just oh, my old eyes are getting blurred here. Oh, talking about fear, that was my next question. So how has fear, among clinicians for sure, regulators, insurers, pharmacies, pharmacists, etc., how has that changed the whole climate of pain care, this fear?
Well, you're probably, let me, I can start. Sure. So, I mean, the climate of fear really came about with recognition of the rise in mortalities and overdose mortalities, and the belief that prescribing opiates leads to some kind of addiction problem, that the prescription process, taking the drugs themselves, is going to lead someone to becoming an addict, despite the fact that the evidence that is out there shows that most people going through surgically opioid naive people who are going through surgeries, who are tracked and followed up after they've received their treatment, they tend to, it has a very small percentage, like 1.5 or less percent of those people actually become addicted to an opioid. So that's, and you can add to that.
So this is typical of what we talk about in our book as prevention 1.0, the way in which the drug problem in America has been addressed has been, for the most part, is to create fear. Just say no. We all heard about that, the slogan, just say no, and that it's a moral issue, and that therefore, if you make the wrong choice, then you need to be punished. That's why we have so many people incarcerated with minor drug problems of possession. I'm not talking about selling, that's a whole different ballgame. But if many people are incarcerated for small amounts of the use of a drug or possession of a drug, which is the form of punishment. So you're going to punish the people who really need more support and medical care rather than incarceration. So it has been that is what we call prevention 1.0. And our book, at the end of the book, after we lay out all of the rationale and reasons and evidence, most of which Sarah is responsible for collecting and analyzing and putting into the book, we lead to proposing how and what solutions are possible realistically over a time frame that we call prevention 2.0.
Hmm. And it's always been my experience, and I've met countless people over the years who have been people in pain, such as myself. And it's always people such as myself and those people in pain don't want to take anything. We just want to be cured. We don't want to take medicine of any kind. We just don't want to be in pain. So if you could cure us, please do that. But that seems to not even be a topic of discussion.
Yeah, it's unfair. I think it's more than unfair. It's tragic, and it's hard for me to understand, having worked in the field and treated people like you for decades. I just don't understand where that lack of compassion is. But it has been replaced, or actually, it's never been replaced because it's always been a matter of blame. So it's easy to blame people, and as Sarah has just mentioned, it's nice that we have simple villains. The prescriber, the patient, pharmaceutical companies. These are easy villains that we can blame, and if it's people with pain, they may not be the villain, but they're certainly they're collateral damage to the overriding issue that has been our narrative, which we feel is a toxic narrative because the narrative is incomplete, if not misleading, and worse, to lead to the abandonment of patients that have real needs to be treated. And again, this is what we've documented in our book. We document the differences and the way in which people can develop vulnerabilities, the social contributions, the ecological contributions, the economic contributions that are longstanding. These can be 30, 40, 50, 60 years in the making of somebody vulnerable to misusing or overdosing on opioids. But these factors are rarely addressed.
Right, and it's so true when you talk about the lack of care for patients. I'll give you a real live example. Anonymously, a client of mine who has rheumatoid arthritis, which you would know is a particularly challenging diagnosis, and we're in a great deal of pain, but especially in one hip. One hip was giving this person a lot of trouble. They were having a difficulty walking, and they were asking their, I guess, neurologist, like, please, can you help me with pain for this hip because I'm losing the ability to walk. They weren't asking for anything in particular, just please, almost begging, can you help me with the pain in my hip? And the answer was, no one with RA should expect to live a pain-free life. That's what this patient was told. They were gutted. I was gutted when I heard it. And I think to myself, what is wrong with people? Like, this isn't a person who is asking for something in particular. They were just saying, please help me. I'm losing the ability to walk.
Well, you highlight something that is unfortunately very, very common today. I continue to get emails from people that I don't know, but they see my writings and they know what I've been trying to do. And so they are asking for help, and they basically continue to tell me, or often tell me, that they're just being abandoned. And I write back to them. You would like to know. I think most people would like to know, why aren't they being treated with some compassionate, individualized care? Well, I think that if you put yourselves in the shoes of at least the physicians and pharmacists, then you realize that what has happened with the narratives, and why they become so toxic, is that it's led physicians to feel they're forced into protecting their own legal and professional risk more than helping patients. And so that means patients really are subjected to all sorts of adverse events, like the forced tapers and the medical abandonment and stigma associated with asking for relief and then being denied it. It's a terrible world for people in pain.
So the physician, talk about fear again, in fear perhaps for their own license, or something to blow back on them if somebody thinks they are prescribing inappropriately, which honestly I believe like 20 odd years ago would have been completely appropriate. It's not appropriate now.
That's true. I think that's why this is the whole book. The toxic narratives have changed the paradigm. It's changed the way in which physicians, the whole healthcare system, not just physicians, the whole healthcare system feels they can treat people with chronic pain. That no one wants to be in litigation. No one wants to go to jail. No one wants people to hurt, I think. Or I hope no one wants that to happen. But for the most part, patients with severe pain have been erased from the conversation. And all because the narrative has said that we have too many pills. And the answer to too many pills is a reduction in pills, not looking upstream to why is there a need for pills, as opposed to, why do they take pills?
Right. Why did they take why did they take pills? Oh gosh. Okay. This is a big one, a big one. Media. When I hear the word media with regards to this subject, all I can think of is hype and hysteria. That's all the only two words that come to mind for me. So, what do you believe the role that media played in their coverage in shaping public attitudes around opioid medications and the patients who needed them, took them, and the prescribers?
Let me start with that a little bit, Sarah, and then please
Sure, I'll join in.
interrupt and add in. But I think that the rush to cover a rapidly mutating crisis like the opioid crisis has led the media to really lean heavily into an oversimplified narrative, which is kind of what I was talking about a few minutes ago. But what they've done frequently is conflated illicit opioids, illicit drugs, the whole family of illicit drugs, not just opioids, but the whole family of illicit drugs, with prescription opioids when analyzing, the root causes of the current problem. They blurred the lines between illicit and prescription opioids until the public can't tell the difference. They don't study it like we do, and they're not often experiencing it like you, Anne-Marie. So they just kind of read the headline, maybe the first paragraph, and they hear this repeatedly by trusted sources like the CDC or maybe the New York Times or CNN or some other media source. And it's repeated so often that it becomes truth to them, even though it's incomplete, often misleading, and sometimes just factually wrong. So the modern media doesn't value the nuance of what we're doing. It values the ability to get attention, spark strong emotions, and affirm an identity. So the question a lot of media outlets is no longer, is it true? But Does it spread? The virality of misinformation is important because that is what generates revenue and promotion and recognition. So, stories that are emotionally resonant, morally straightforward, and offer a clear villain are the ones that go viral. A complex data driven story about social economic despair and a 50-year drug trend doesn't spread very easily because it's very complicated to discuss and communicate. And that, by the way, is exactly what Sarah has been able to do with our book. She's been able to bring all of that data and information in a way for people to understand, and I hope we'll be able to repeat to family, friends, and maybe policymakers that they know.
I was just going to say, Dr. Eichberg, when you see or have read these media articles and published things, I never see the word illicit. I never. It's just those demon opioids. So when you see things like this, you must feel like that's just appropriate for the shredder.
That's why we wrote the book.
Yeah, I mean that's the initial reaction, but it's ridiculous. But I also wanted to add that within, not just with like the media's attention on virality and getting everything to spread and getting attention, how that's altered storytelling and also affected people with pain. There's also the fact that the media has also created these stories along racial, has sort of created a two-tiered level of to the story of drug use, and so it perpetuates that through what they're doing.
Sarah, you should explain that a little more. Discuss
What are these two tiers? I'm interested.
Yeah, discuss the differences between racial, geographic areas and things like this, which we.
Oh, sure. Well, just focusing on the media.
Okay.
There's been a difference in terms of how the opioid crisis has been portrayed and the crack cocaine situation that mostly affected African Americans or other people of color, and then the opioid prescription crisis, quote unquote, that affected mainly white people. So basically, I think we all can kind of remember back with the crack cocaine, basically people who were ravaged by it, really, but people who used it were represented as moral failures, as people who needed to take personal accountability, as, basically as not as the heroes of their own story by any stretch of the imagination. And in turn, with the opioid crisis, it's really been centered as a story of white middle class people who are victims, not the perpetrators like they are with crack cocaine, but the victims and sort of helpless, deserve sympathy. People
now we have a problem because we have a large white population. Now we have a problem.
Yeah.
As opposed to when it was, like you said.
Oh, sorry. Yes.
Yeah,
it is. Now we have
mostly, those people, and and I would never use that term, those people, but I'm just, summarizing that wasn't that was what it was. It's sad, but we can't do anything. But now we have a problem.
Well, before it was criminal, and now it's about public health.
Okay, so now we have a public health problem, not just criminals.
Yes, exactly. So that's how race works, or at least one way that race works in the media.
We explain in the book, I think with considerable depth, the racial inequities in society that basically have had a huge influence on the opioid crisis, because people probably don't realize this from reading the media for the reasons that Sarah just explained. But the populations that are most affected are not white people. it's black, it's
Native
American
American,
Indians,
yeah,
huge, like double the rate of
yes.
opioid overdoses and substance abuse problems, right, Sarah?
It's still going up as rates are going down
Here
for
as
other.
well, yes,
Yeah.
here as well. So is that what you meant by the two-tier?
Yeah, it's a two-tiered. Well, it's a two-tiered media approach. There's also a two-tiered approach within the practice of medicine and prescribing pain medications for patients. So, and that exists basically. Um, there is a bias that plays into interactions between doctors and their patients, and there's a lot of literature supporting this, that basically doctors interact with their black patients with a perception that they don't need pain relief in the same way that white people, but I don't think it's conscious like that, but it's a notion that they carry into those interactions, and as a result the uh, blacks, people of color, are um, prescribed opioids much less often than whites are.
Is this supposed to be something physiological, like that population does not feel pain the way I
Well,
might?
yeah, there's some. It has roots in that have been somewhat tweaked, but still inform the medical system.
Yeah, there was a study of a medical school, medical students actually, and their attitudes towards how different races perceive the same stimulus of pain. And these were medical students who had reported that African Americans do not feel the same level of pain as whites with the same stimulus, which of course is which is of course not true. It's
What is the basis of that?
no, it's racism. It's just racism.
That's
You know,
it. That's just
it's just the base blatant racism. Yeah.
okay. Okay. Yeah, well, it's also here extremely difficult if you are an indigenous person in pain. Might be, you've never abused anything in your entire life, but for some reason you should not have access to this because it's like well, like you said, so toxic. It's like if we give you one pain pill, 10 minutes later you're going to be looking for heroin. Like it's so beyond anything realistic or rational or even reasonable. It's hard to understand, and there's zero compassion there. It is full on racism. It is in the medical offices. So very very difficult, very difficult. As if it weren't difficult enough already. So I just sort of with the media, sort of not really. Here's my question. It was one of our listeners had asked me this, who knew that you were coming on, and the question was this: there are many groups in Canada, I'm sure in the U.S. They are posed as pain groups, like pain support this or pain support that, or I really don't know the names. Pain Coalition, Pain Association. I'm not sure, but they do a really good job of kiboshing what the rest of us would like to change, these groups. They have a lot to say too, and a lot of power. Their voices are big. And I'm wondering, is there any knowledge or literature or research out there that would acknowledge these groups? And the question was, is there any way to even help neutralize these louder voices that may not be involved in public policy or may not be physicians or pharmacies? However, they're groups unto their own with big voices.
I'm not sure I can respond to that specifically without knowing what the groups are saying and doing and what their literature is. Well, what are they trying to do that?
Well, their message is basically the same. That they're basically like no opiates. Opiates are not a good thing. They're very dangerous. They're very harmful. Somebody, I think it was not a pharmacist, a physician on your side in the U.S. somewhere who made this posting, in that If I withhold one opioid medication for one patient, I'm not only saving that patient, I'm saving their whole community.
Yeah.
So
Well,
these are the messages, and they're loud. They're loud messages.
yeah, that's part of what we write about. I mean, these are part of the narratives that are toxic, because how could that not be toxic, right? I mean, how could something like that, which is flatly wrong and an opinion, it's a dangerous opinion, and it is an act that literally harms people. What can you do? I think that I do not think that you should respond with emotion. I think you need to. I think you need evidence. I think you need data, and that's again why Sarah and I wrote this book. It is to provide a better perspective of what has um, caused the crisis, and that what has been said is incomplete, if not misleading, and oftentimes false, just not true. You know, people suffering uh, from chronic pain or struggling with addiction, as far as that goes, you have to keep in mind that this is really just a canary in the coal mine. The struggle is a signal. When they're struggling, people with pain, or or particularly those with addiction, because that's what our book is about. There's an underlying social structure that is failing. That's the reason why most of the addictions occur. So we say in the book, and I argue today, that really truly to solve this problem and to counter those people that you were just mentioning, Anne Marie, is is to stop asking why the drug. See, the doc was just focusing on the drug, right? To stop asking why the drug and start asking why the pain. Why are they suffering? It is far more complicated to understand what the upstream crises are, or the upstream issues are, that are contributing to the downstream consequences. Of course, drugs like fentanyl are dangerous. These are not prescription drugs. I mean, fentanyl can be a prescribed drug, but that's not what is causing the overdose deaths. But the reason people take it are the reason they have a need. That is the canary in the coal mine. They're crying out for help. And most of this is structural in your country, my country, and every country that has a drug problem. And every country does have a drug problem, some greater than others.
In the course of history, has there ever been a time when there have not been challenges and struggles with addiction? Hasn't that always been?
That's a part of being human.
That's
That's
what
about, yeah, it's
I,
about,
I understood. It was always a thing, and yeah, now we have the situation's a little bit different, but now we have
look,
when you,
we are always seeking to feel better, to feel good. But most importantly, we seek to relieve our pain. Addiction is no different. Most addictions are developed because of psychological, emotional, societal pain that they're experiencing, adverse childhood experiences, income indisparity, lack of jobs, despair, the deaths of despair that Case and Deaton wrote about is valid. And we support basically what they have written, but we go into greater depth to talk about many of the factors that have contributed to the opioid component of deaths of despair. But forever, from the beginning of time, the beginning of humans, and whether you're a human or an animal, we all try to escape pain. Now, what form of pain? All forms of pain. And if we can't do it because of social connection, because of our because of our relationships, because of access to healthcare, because we have adequate housing and support, we may resort to using drugs to escape from the misery.
Absolutely. I wonder this whole notion of us being, I guess, bombarded by these messages again and again and again, and we come to believe them as the truth when they're not the truth, like the media messages. I wonder if there's ever been such a societal upheaval as there is now, where it's so easy just to say anything based on your own opinion and have people believe you.
Yeah, well, that's what I was just. I mean, that's the media discussion we had here. Harari is an author that wrote a book called Nexus, and we cite him in our book because I think he has some profound insight that historically you could go into depth and write good news articles, and there would be a lot of nuance in those. But today the social media platforms for the most part, but not just social media, all platforms, it isn't what is true that's important. It's will it spread. So it's the virality of it. And you tend to reinforce this. I mean, it tends to be reinforced, I should say, by echoing or being heard by the people who most want to hear it. So it's not about conveying, communicating truth. It's conveying a feeling, an emotion that can get you clicks because that's where the revenue is.
It's also frightening. It's
It is
also
frightening.
frightening. Okay. So after you finished all your good work, did you come to a conclusion? What changes would you most like to see in healthcare, public policy, public understanding, so that people in pain are seen and heard and treated with dignity and compassion?
Well, I think that fits into our Lynn's prior mention about the Prevention Framework 2.0, and that um, offers some potential solutions for people with pain and also for people that are using drugs. Basically, um, we're interested, I think, in the 2.0 frame offering sort of a sense of greater or creating more interconnectedness between all different sort of agencies and hospital systems, and creating more of a continuum of care so that people are able to get engaged in prevention programs, and whatever else they need if there are other things that develop along the way. There's also the interconnectedness, the continuum of care. Humility is also something that we've emphasized. Like uh, doctors need to basically accept that they can be wrong and think about what they're doing. We've also emphasizing dignity for people with pain, and that needs to become part of not just individual interactions between patient and doctor, but also a national approach, and that needs to also be represented in several structural reforms that we recommend in the book.
We have a long list of
Yeah.
recommendations, and we've actually suggested phasing of how that could be done in a realistic way. But fundamentally, we need a shift, a paradigm shift in our thinking about what has caused or continues to contribute to the crisis. Traditionally, as I said, prevention 1.0 was to blame and solve the addiction problem here and everywhere by just simply reducing the supply line. We know that's not going to work. Instead, what Sarah and I suggest or recommend is that we focus on the environment that creates the demand in the first place. And so, policymakers, we believe, must understand this main lesson when it comes to the people with severe pain. You can't take a population level rule, metrics like certain milligrams or a number of days of medication, etc., and apply it appropriately, because healthcare is really a patient physician relationship issue. And that's what should guide care, not arbitrary dose limits or bureaucratic checkboxes that don't allow individual care. We need a healthcare and public policy that invests heavily in community health. That's what Sarah was just mentioning. But also, we propose that there need to be some form of economic stability, early mental health support.
Absolutely. Absolutely. Early mental health support, early, early
It's got to be early.
health in all categories, I guess, including, like a lack of extreme poverty, a lack of there's a huge lack of education in some areas. There's disparities in different places that people live in, and you can see these pockets of disparities. And I don't know if I'm wrong, but it seems like those pockets of disparities also have higher rates of even criminal behavior, which I'm not talking about the use of addictions and substance abuse and whatever, but I think they have higher rates of it where there's less help, there's less support, there's less of everything.
All of that's true, and it parallels with what we talk about in the book about the roots, the seeds to opioid overdose deaths. I really think we need to move beyond the blaming, and toward a more systemic understanding. People with pain should be seen, heard, and treated with dignity.
Dr. Eckberg, you were going to say?
I just wanted to say, I think one section in our book does a basic overview of studies that are out there that we use a risk environment framework is what it's called.
Oh, yeah.
And we use it to look at how local settings and larger social structural conditions interact very place specifically to create different kinds of drug behaviors and outcomes. That's valuable because you can read the chapter and it brings in the voices of the people who are affected by these local conditions. And I think that's kind of representative. It's explaining how localized processes interact with larger forces to create experiences with drugs, but it's also, emphasizing the fact that these voices matter and that they need to be included in the conversation, and that can be extended to people living with pain as well. So I think that's something that there could be more attention perhaps placed on in, I don't know the state of the research in your area, but perhaps, yeah.
It's probably similar.
Yeah.
The only thing I think that is like a major difference is I forget the name of it. In Canada, we have this policy set out so that each province gets what it needs, I guess, per capita from money from the federal government. So we don't have a great pocket of wealth beside a great pocket of disparity because it's equalization payments. That's what they're called. So we don't have one province that's kind of left out in the cold with regards to money and resources and whatever. So we have that, which I don't think exists in the US. And I think that's about the only difference that I can think of.
Right.
Other than that, it's probably very similar.
Yeah.
And I can tell you the doctors and the attitudes and the media and all that, it's bang on. It's exactly the same thing.
Well, one thing that I would, sorry for interrupting, but one thing that I would point out that, in our currently in the States, we're having, under the current administration, there are a lot of efforts to take away programs and take away interventions that have shown to have a lot of success in in helping people who use opioids or other drugs, and I don't think you have quite the same political climate, maybe.
Yeah, a little bit different. Although, like we have different parties, and the conservative parties, their typical take has been criminalization is the way to go. Take it away, blame. That's typically a conservative stance over here. Yeah, but I mean, things are different all over the world right now in their own little areas. Although we're suffering in the same ways. And what a fascinating conversation. I'm so glad that you collaborated to write this book. I think a lot of people are going to be very interested, and I hope it opens a lot of eyes. So, Deconstructing Toxic Narratives, where can one purchase this book?
It's on Amazon and on Springer, both of them. Yep.
Amazon or Springer?
Yep.
On both. Okay.
Well, I think everywhere, but for
Barnes
sure.
and Nobles, et cetera, et cetera.
Oh,
Yeah.
okay. Okay. Well, if you didn't have anything to add to the conversation, I just wanted to thank you so very much for coming on and letting us know about this new book, about your new work. And it's so encouraging to me personally to know that you're out there still trying to help, still trying to make things right, still trying to make things better for people just like myself and hopefully for younger people to come. So thank you.
I would like to add one comment, which it's kind of my signature, but it underscores everything I believe, and that is compassion must lead us forward, but science must light the way.
Is that your quote?
That's my quote. That's the thing that I live by, and that's what our book is too.
Okay, wonderful. I'll be sure to include that. Thank you again. Enjoy the rest of the week and the weekend.
Thank you for taking us
Thank
on.
you.
Okay.
Thank you for having us.
Okay, my pleasure. Very welcome. Take care. Bye-bye.
Thanks. Bye.
Thanks for tuning in to the Pain Pod. If you enjoyed this episode, be sure to subscribe so you never miss a future show. Share this with your friends, and if you're so inclined, give us that 5-star review and comment. We hope these podcasts motivate you to get involved with us at chronicpaincanada.com. Until next time.